Thank you very much for the introduction, Brad. First of all, it's an honor to present this paper on behalf of the University Hospital of Cologne. And what we did here is an off-label compassionate use of the Sonolief system using hyperthermia for a sarcoma patient, which was 59 years old, male, and he suffered from a dedifferentiated liposarcoma originating from the spermatic cord. He was late stage, meaning that the tumor was already infiltrating vein, bladder, and bone, and there was some pulmonal metastasis as well as metastasis in psoas muscle. In red, you can see here the tumor location, and he suffered also quite some pain as well as some pressure on his bladder. So he had already a long history of chemotherapeutic therapies as well as radiation therapy, but he was offered an alternative or a new one, which is just a combination of an infusion of olaratumab, which is a platelet-derived growth factor receptor alpha antibody, and then followed by an infusion of doxorubicin. The oncologist who treated him asked us if it would be possible to add some things to the infusion with dox. This was then MR-guided HIFU hyperthermia. But since the patient had some pressure on the bladder, he could only lay for half an hour on the table. So that means that we split a little bit the whole treatment in the prep and planning phase, followed by doxorubicin infusion during hyperthermia. So technically, this was an ideal case for us. So the goal was for 30 minutes of hyperthermia, and this whole treatment was repeated every 3 weeks. So technically, this was a very easy case for us, or an interesting case for us, because since we can place very nicely in a 3.2 millimeters treatment cell just in front of the bladder, so that the far field was covered by the bladder itself, and the depth was around 4 to 5 centimeters from the skin. So we said, okay, we use just a standard 1.2 megahertz frequency, and we limited ourselves to 60 watts of acoustic power. Such a 3.2 centimeters treatment cell is, of course, not available just by electronic deflection. So we use a combination, which was already published by Matti Tillander, where he developed a method where he used a subcell, which is just use the electronic deflection and then going to the next subcell by moving the transducer. And binary feedback was implemented, meaning in 2 levels. First of all, on the focal spot level, that is also the pixel level you get from the temperature map, that if the temperature was lower than 42 degrees, the spot was sonicated, and if the subcell reached a temperature on the mean on 42.5 degrees, then he moved to the next subcell. What we add to that was a manual hyperthermia controller to get some more information on it, on the status of the different subcells as well, to be able to intervene and pause without stopping the temperature map. So I will show you an example of the first treatment we did. So the white circle you'll see is the 3.2 centimeters treatment cell. And this is just a temperature map overlaid with the MR temperature magnitude image. On the top right, you'll see a histogram from the white circle of the temperature distribution, and on the top left, top lower right, then you will see the average and the T90 and T10 temperatures in this region. So what you see is that we start, of course, with the preparation phase, so baseline are taken for every position, and then the whole sonication starts, and you see that individual subcells are first sonicated and heated, and that you then go over into kind of a maintenance phase where you maintain the temperature in this whole region for a longer period of time, and then after a certain way we stopped this treatment. So in temperature was then reached around 42 degrees Celsius. You see also in brown the duty cycle of the power, which was a little bit balanced here. If you look to other treatments we did afterwards, so this was the second one, which was the same power, then we see that the power was a little bit limited. So we have a high duty cycle on the power level. The second part of this treatment was not that successful, and even we increased the power to 80 watts, and we still not get a nice balance between the power duty cycle and the temperature. And you see also that the temperature decreases over time. So in conclusion, we had no adverse effect by this patient. He tolerated it very well. Heat-up period was around 3 minutes, and the total hyperthermia period we gained in these 3 sessions was 56 minutes. The manual hyperthermia controller was really appreciated by our physician. We see that we need more power. That's definitely more important. And I would refer to a talk of Lucas Sebekidis, where the power is a little bit calculated up front instead of using a fixed one. And still we have some motion artifacts, so we are quite limited to the duration of the hyperthermia period. So we'd like to thank the whole team, our funding agencies, and I would like to especially thank Profile Medical as well, the University of Cologne, for sponsoring me to give this talk here on this fabulous conference. And I would like to thank you, and I'm open for questions.
Very quick questions. Now, what kind of, and Pavel, come on up for the next talk while we're doing the question. What kind of volumes can you get reliably at 42 degrees?
Now, yeah, the maximum is around 5 centimeters, which is now implemented in the system. That I think it's quite challenging already. We took this 3.2 because it fitted exactly in this small corner of the tumor, and that we had the least risk to have some adverse effect.
Cool. So interstitial hyperthermia. Yeah. All right. Thanks much, Edwin.
I'd like to introduce